There is a sensation that an estimated 15% of all American adults experience, and that percentage climbs sharply with age, reaching somewhere between 25 and 35% in adults over 65, a sensation that happens specifically at night, specifically when the body is at rest, that is uncomfortable enough to disrupt sleep but not dramatic enough to send most people to a physician, and that the majority of people who experience it have explained away with a phrase that is both widely used and almost completely wrong. They call it restless legs. They say their legs are restless at night, and most of them have been told, if they have told anyone at all, that it is just one of those things, a quirk of their nervous system, a minor sleep nuisance, something to manage with stretching or a warm bath before bed. What the neurological research has been showing for the last 20 years is that this sensation, this specific, undeniable urge to move the legs that arrives in the evening and at night, that is worse during rest and relieved by movement, that is described by the people who experience it as crawling, creeping, pulling, throbbing, itching deep in the muscle, or an electric discomfort they cannot locate and cannot ignore, is not a quirk. It is not simply restless legs in the colloquial sense of a minor nervous habit. It is a recognized neurological condition with a clinical name, a specific diagnostic criteria set, and a body of research connecting it, when undiagnosed and unmanaged, to a cluster of systemic health conditions that go far beyond sleep quality. Conditions that most people who have been lying awake at 2 a.m., moving their legs to get relief, have never once connected to the sensation they are experiencing. I am going to walk you through what this condition actually is, what the neuroscience tells us about what is happening in the central nervous system when it produces this sensation, and what the research, which has expanded dramatically in the last decade, shows about the connection between this nighttime leg feeling and cardiovascular disease, kidney function, iron metabolism, dopaminergic pathway health, and in the most recent and most concerning literature, cognitive aging and dementia risk. I am going to give you the specific diagnostic criteria so that you can recognize whether what you are experiencing qualifies as this condition by clinical standards. And I am going to give you a specific, research-grounded intervention protocol that targets the biological mechanisms driving the sensation, because the default management of this condition in most clinical settings falls significantly short of what the evidence supports, and most people who have it are either not being treated at all or are being offered only one layer of intervention when several are available and evidence-backed. My name is Dr. Patricia Huang. I have practiced neurology for 22 years with a subspecialty focus on sleep neurology and movement disorders. The condition I'm describing is Restless Legs Syndrome, RLSN, which is also called Willis-Ekbom disease in the modern clinical literature, named after the two physicians whose work in the 17th and 20th centuries respectively first characterized and then formally defined it as a neurological condition rather than a psychiatric one. It is one of the most common neurological conditions in the world and one of the most underdiagnosed because its symptoms occur during a period, the evening and nighttime, when most people are not in a physician's office because its description tends to sound vague or subjective when patients attempt to describe it, and because the medical system has historically been slow to take sleep-disrupting symptoms as seriously as daytime symptoms in clinical evaluation. Before we go further, I want to hear from you. Drop where you are watching from in the comments, and if you experience this uncomfortable urge to move your legs specifically at night or in the evening when you are at rest, the creeping, crawling, pulling feeling that improves when you get up and walk, type yes in the comments right now. I want to know how many people watching this have been living with this without knowing what it is. Let me give you the clinical diagnostic criteria for restless leg syndrome, because many people who have it do not recognize it under that name and have never matched their experience to the formal definition. The International Restless Legs Syndrome Study Group, the primary clinical body that defines this condition, specifies 5 criteria that must all be present for a diagnosis. First, an urge to move the legs, usually accompanied by or caused by uncomfortable sensations in the legs. Second, the urge to move or the unpleasant sensations begin or worsen during periods of rest or inactivity such as lying down or sitting. Third, the urge to move or unpleasant sensations are partially or totally relieved by movement such as walking or stretching, at least temporarily and as long as the activity continues. Fourth, the urge to move or unpleasant sensations are worse in the evening or nighttime hours than during the day, or only occur in the evening or nighttime. Fifth, these features are not solely accounted for by another medical condition or a behavioral condition. If all five of those criteria describe your evening and nighttime leg experience, you meet the clinical diagnostic criteria for restless legs syndrome by the International Study Group's definition, regardless of whether any physician has ever told you that. The condition is significantly more common than most people realize. A systematic review and meta-analysis published in the journal Sleep Medicine Reviews estimated a global prevalence of approximately 14.5% of the general population, rising to 25 to 35% in adults over 65 and to even higher rates in specific populations: adults with chronic kidney disease, adults with iron deficiency, pregnant women, and adults taking certain medications I will describe shortly. Despite this prevalence, a study published in the European Journal of Neurology found that the average delay between symptom onset and correct diagnosis of restless leg syndrome is approximately 12 years. 12 years of disrupted sleep, of nocturnal leg discomfort, of unexplained fatigue, of the secondary consequences of chronic sleep deprivation, before most people receive an accurate clinical explanation for what they have been experiencing. That diagnostic gap is one of the primary reasons I am making this video. Now, I want to explain what is actually happening in the nervous system when RLS produces its characteristic sensation, because the mechanism is both fascinating and clinically important. It determines why the condition responds to the interventions it responds to, and why it fails to respond to the ones it fails to respond to. The primary neurological driver of restless leg syndrome is dopaminergic pathway dysregulation in the central nervous system. Dopamine is a neurotransmitter that most people associate with pleasure and reward. It plays a central role in the brain's reward circuitry and is the neurotransmitter depleted in Parkinson's disease. But dopamine has a second, less publicly known function. It plays a critical role in the regulation of sensory motor processing, specifically in the modulation of sensory signals from the body and in the gating of motor impulses. In people with restless leg syndrome, the dopaminergic pathways involved in this sensory motor gating function, particularly pathways involving the A11 dopaminergic cell group in the hypothalamus and diencephalon, which sends projections down the spinal cord, appear to be dysfunctional. The result is that sensory signals from the legs, which in a normally functioning dopaminergic system would be appropriately filtered and modulated, instead produce an abnormally amplified and distorted sensory experience accompanied by motor urgency, the irresistible urge to move that is the defining feature of the condition. The circadian nature of the symptom, worse at night, minimal or absent during the day, reflects the circadian rhythm of dopaminergic activity. Dopamine levels and dopaminergic signaling efficiency follow a circadian pattern that is at its lowest in the evening and early night hours, which explains precisely why the symptom is most severe during that window. This circadian mechanism also explains why the standard pharmacological treatments for RLS, dopamine agonist medications including pramipexole sold as Mirapex and ropinirole sold as Requip, which are the same class of drugs used in Parkinson's disease management, are effective for many patients but also why they carry significant long-term risks, including a phenomenon called augmentation, where the medication progressively worsens the condition it was prescribed to treat, requiring earlier dosing and higher doses over time. But the dopaminergic pathway is not the only biological system involved in RLS, and this is where the systemic health connections become significant. The second critical mechanism in restless legs syndrome is iron, specifically brain iron deficiency, iron insufficiency in the substantia nigra and other regions of the brain that are central to dopaminergic signaling is one of the most consistently identified pathological findings in RLS. Iron is an essential cofactor for tyrosine hydroxylase, the enzyme responsible for converting tyrosine to LDOPA, the immediate precursor to dopamine. Without adequate iron, dopamine synthesis is impaired at the enzymatic level. A study published in the journal Neurology found that the concentration of iron in the substantia nigra, measured by both MRI iron-sensitive imaging and by cerebrospinal fluid ferritin concentration, was significantly reduced in RLS patients compared to age-matched controls, even in patients whose serum ferritin was within what is considered a normal clinical range. This is a critically important finding that I want to explain carefully. The standard iron test that most physicians order, serum ferritin, measures circulating iron stores in the blood. A serum ferritin above 12 to 20 micrograms per liter is considered normal by most laboratory reference ranges, but the research on brain iron in RLS consistently shows that brain iron sufficiency requires serum ferritin levels significantly above what is considered a normal clinical range. Multiple RLS research groups have concluded that a serum ferritin below 75 micrograms per liter is associated with RLS symptom severity, and that increasing serum ferritin toward 100 to 200 micrograms per liter produces measurable improvement in RLS symptoms in iron-deficient patients. The normal laboratory range is not the therapeutic target for RLS. The therapeutic target is substantially higher, and most patients with RLS who have had iron tested have been told their iron is fine because it is above the laboratory minimum, without anyone explaining that the minimum and the therapeutic target for their specific condition are not the same number. The specific request I am asking you to make at your next physician appointment, if you have RLS symptoms, is not simply to have your iron checked. It is to have your serum ferritin specifically measured and to ask for the number, not a normal or abnormal interpretation, the actual number I, and to ask your physician whether, given your RLS symptoms, a ferritin level below 75 warrants a trial of iron supplementation. That specific targeted conversation changes what happens next in your clinical management. Now, I want to address the systemic health connections that the research is identifying with restless leg syndrome, because this is the dimension of the condition that most people with RLS have never heard about, and that most dramatically reframes how seriously the condition deserves to be taken. The cardiovascular connection is one of the most concerning findings in the recent RLS literature. A study published in Circulation, the flagship journal of the American Heart Association, followed over 65,000 women in the Nurses' Health Study and found that women with RLS had a significantly elevated risk of cardiovascular mortality compared to women without RLS, with the risk of dying from cardiovascular disease approximately 39% higher in the RLS group after controlling for age, BMI, physical activity, and other cardiovascular risk factors. A separate study published in the American Journal of Medicine found that RLS was independently associated with hypertension after controlling for sleep duration and sleep quality, suggesting that the cardiovascular risk associated with RLS is not entirely mediated through sleep disruption alone, but may involve direct pathophysiological mechanisms. A study published in the Clinical Journal of the American Society of Nephrology found that RLS was independently associated with more rapid decline in kidney function over a 4-year follow-up period in adults with existing chronic kidney disease. The cognitive connection is the most recent and in some ways the most alarming thread in the research. A study published in JAMA Neurology in 2022 analyzed data from the UK Biobank, one of the largest longitudinal health databases in the world, covering over 500,000 participants, and found that RLS was independently associated with a 27% increased risk of dementia diagnosis after controlling for sleep duration, cardiovascular risk factors, and other potential confounders. The proposed mechanisms are multiple. Chronic sleep fragmentation caused by RLS disrupts the glymphatic clearance of amyloid beta during slow-wave sleep, the same mechanism I described in the context of television sleep and smartphone use. The dopaminergic pathway dysregulation that drives RLS overlaps with dopaminergic systems involved in cognitive processing and in the early pathophysiology of Lewy body dementia. I want to tell you about a patient I will call Helen. Helen was 72 when she came to my clinic, referred by her internist because she was complaining of persistent daytime fatigue that had not responded to any intervention. She was sleeping 7 to 8 hours by clock time every night. She did not feel she was waking up, at least not fully. She just felt every morning as though she had not slept, Her husband had mentioned that she sometimes moved her legs quite a bit in bed. She had not thought to mention this to her previous physician because she did not feel it was relevant to her fatigue. When she described it to me, the clinical picture assembled itself in under 5 minutes. Every evening, starting around 9 p.m., she experienced a deep, crawling discomfort in both lower legs that forced her to move them continuously. She paced the hallway for 20 to 30 minutes before she was comfortable enough to attempt sleep. Once asleep, her husband reported, she kicked regularly throughout the night, a phenomenon called periodic limb movements in sleep, which is a distinct but closely related motor phenomenon present in the majority of adults with RLS. She had been managing this with a warm bath before bed for approximately 8 years. She had never mentioned it to a physician. She did not know it had a name. Her serum ferritin was 31 micrograms per liter, within the normal laboratory range but well below the 75 microgram threshold associated with meaningful brain iron sufficiency in RLS. A polysomnography study documented 47 periodic limb movements per hour of sleep, a severe level of sleep-disrupting motor activity. Her daytime fatigue, which she and her previous physicians had attributed to depression, to thyroid function, to sleep hygiene, was the straightforward consequence of a sleep architecture that was being shattered 47 times per hour by a condition nobody had named. What I gave Helen is the same multi-layer protocol I am going to describe to you now, because addressing RLS effectively requires targeting its multiple biological drivers simultaneously rather than reaching for a single pharmacological solution that addresses dopamine signaling without addressing iron, without addressing the dietary factors that modulate dopaminergic function, and without addressing the augmentation risk that comes with long-term dopamine agonist use. The first intervention is iron optimization. If your serum ferritin is below 75 micrograms per liter, iron supplementation is the most directly evidence-supported intervention available for RLS. The form of iron matters significantly. Ferrous sulfate, the most common form in standard iron supplements, has meaningful gastrointestinal side effects including constipation and nausea at the doses needed to raise ferritin substantially. Ferrous bisglycinate chelate is a form of iron that is significantly better absorbed than ferrous sulfate, with substantially fewer gastrointestinal side effects, and that has been specifically studied in RLS populations. Thorn iron bisglycinate, available on Amazon and at Whole Foods for approximately $15 to $22 for a 60-count supply, provides 25 milligrams of elemental iron as ferrous bisglycinate per capsule in a form that the research shows reaches brain iron stores more effectively than standard iron formulations. A clinical trial published in the journal Sleep Medicine found that oral iron supplementation raised serum ferritin toward the 75 to 100 microgram target and produced significant reduction in RLS symptom severity compared to placebo over 12 weeks in patients with ferritin below 75. Iron supplementation should be taken with 500 milligrams of vitamin C, standard ascorbic acid, available as nature-made vitamin C, 500 milligrams at Walmart, Target, and virtually any pharmacy for under $10 for a 100-count bottle Y, which increases non-heme iron absorption by 2 to 3 times by maintaining iron in its reduced, absorbable ferrous form in the acidic environment of the stomach. Take iron and vitamin C together on an empty stomach in the morning for maximum absorption, and avoid taking them with coffee, tea, calcium supplements, or antacids, which significantly reduce iron absorption. Have your ferritin rechecked at 8 to 12 weeks to assess response. The therapeutic target is a ferritin between 75 and 200 micrograms per liter. The second intervention is dopamine pathway nutritional support, targeting the substrate availability for dopamine synthesis, rather than using pharmacological dopamine agonists that carry augmentation risk. Dopamine synthesis requires 3 nutritional inputs: iron, which I have addressed, vitamin B6 in its active form, pyridoxal 5-phosphate or P5P, which is a cofactor for aromatic L-amino acid decarboxylase, the enzyme that converts L-dopa to dopamine, and the amino acid L-tyrosine, the dietary precursor to L-dopa and dopamine. A study published in the journal Nutrients found that pyridoxal 5-phosphate supplementation at 100 milligrams per day improved RLS symptom scores significantly compared to placebo in a randomized controlled trial conducted in adults with moderate to severe RLS. Jarrow formulas P5P50, providing 50 milligrams of pyridoxal 5-phosphate per capsule, available on Amazon and at Whole Foods for approximately $12 to $18 for a 60-count bottle. Taken twice daily with meals, supports the enzymatic step in dopamine synthesis that is downstream of iron and upstream of the dopamine molecule itself. This is not pharmacological dopamine replacement. It is nutritional support for the biological process that dopamine agonist medications are compensating for pharmacologically. The distinction matters because the nutritional approach does not carry augmentation risk. The third intervention targets a mechanism that most RLS discussions entirely omit: glutamate excitotoxicity in the spinal sensorimotor pathways. Glutamate is the primary excitatory neurotransmitter in the central nervous system, and in restless leg syndrome, the spinal circuits that generate the uncomfortable sensory experience and the motor urgency appear to be in a state of glutamate-driven hyperexcitability, an imbalance between glutamatergic excitation and GABAergic inhibition in the spinal dorsal horn and supraspinal processing circuits. This is one of the reasons that magnesium, a natural NMDA receptor antagonist that reduces glutamate-driven excitatory signaling, has been found to be beneficial in RLS management in multiple clinical observations. A study published in Sleep found that magnesium supplementation significantly improved periodic limb movements in sleep and subjective sleep quality in adults with insomnia and RLS compared to placebo. The specific formulation of magnesium matters. Magnesium oxide, the most common form in inexpensive supplements, has poor bioavailability and is primarily a laxative at higher doses. Magnesium glycinate, magnesium bound to the amino acid glycine, has the highest bioavailability and is the gentlest on the gastrointestinal system. Glycine itself has additional sleep-promoting properties that make this form doubly appropriate for an evening supplement targeting a nighttime condition. Pure Encapsulations Magnesium Glycinate, available on Amazon for approximately $25 to $35 for a 90-count supply, provides 120 milligrams of elemental magnesium per capsule. A dose of 2 capsules, 240 milligrams of elemental magnesium, taken 1 to 2 hours before the typical symptom onset time, addresses the glutamatergic hyperexcitability mechanism at the point in the evening when it is most clinically relevant. The fourth intervention addresses a dietary factor that the RLS research has identified as a consistent aggravator of symptoms and that most people with the condition have never been told about. Dietary compounds that suppress dopaminergic signaling or that increase glutamate-driven excitability in the spinal pathways worsen RLS symptoms measurably in clinical studies. The two most significant in the diet are alcohol and caffeine, but their mechanism and timing sensitivity are specific enough to warrant precise guidance rather than general avoidance advice. Alcohol suppresses dopamine release in the mesolimbic and nigrostriatal pathways acutely, producing an apparent relaxing effect, but then produces a rebound dopaminergic suppression in the hours following as alcohol is metabolized, which corresponds precisely to the evening window when RLS symptoms are worst. Regular alcohol consumption in the evening thus paradoxically worsens the very condition it may briefly appear to relieve. A study published in the Journal of Psychosomatic Research found that alcohol consumption was independently associated with greater RLS symptom severity in a large cohort of adults with the condition. Caffeine suppresses adenosine receptors. Adenosine is the brain's primary sleep pressure molecule. An elevated adenosine in the evening appears to have a modulatory effect on the dopaminergic pathways involved in RLS. When caffeine blocks adenosine signaling throughout the day and into the evening, it removes a natural dopaminergic modulator at precisely the time when dopaminergic activity is already at its circadian nadir. A study published in Sleep Medicine found that caffeine consumption, particularly in the afternoon and evening hours, was significantly correlated with RLS symptom severity in a dose-dependent manner. The practical guidance is to eliminate caffeine after 1 p.m. and eliminate alcohol consumption in the 4 hours before the typical RLS symptom onset time, which for most adults means no alcohol after 5 to 6 p.m. The fifth intervention is a specific behavioral technique called counterstimulation, which is underused and undervalued in RLS management, despite having the most immediate symptom relief available without pharmacological intervention. Counterstimulation involves the application of tactile or temperature stimuli to the legs during symptom onset to engage the somatosensory processing pathways in a way that competes with and partially suppresses the abnormal sensory signal generating the RLS discomfort. The most effective counterstimulation modalities documented in the research include compression, specifically compression leg wraps or pneumatic compression garments, vibration, and cold water immersion. A randomized controlled trial published in the Journal of Clinical Sleep Medicine found that near-infrared light therapy applied to the posterior legs for 30 minutes before the typical symptom onset time significantly reduced RLS symptom severity, proposing a mechanism involving nitric oxide release in the vasculature and peripheral nerve tissue that modulates the abnormal sensory processing generating symptoms. The Javgo portable near-infrared light therapy device, available on Amazon for approximately $295 to $350, is one of the clinically studied near-infrared therapy formats that has been specifically evaluated in RLS populations. For those for whom the device is not accessible, a simple compression knee-high stocking, such as Sigvaris Wellbeing Cotton Compression Socks, available at most pharmacies for approximately $20 to $30 per pair, applied in the evening from the point of symptom onset, provides the tactile counterstimulation input that the somatosensory gating research supports as a partial symptom modifier. Helen, at her 6-month follow-up, had implemented iron supplementation. Her ferritin had risen from 31 to 89 micrograms per liter. She was taking P5P twice daily and magnesium glycinate every evening. She had eliminated alcohol and was drinking no caffeine after noon. She had acquired compression socks. Her periodic limb movement index on a repeat sleep study had fallen from 47 per hour to 11 per hour, still elevated above normal, but representing a dramatic reduction in her nocturnal motor disruption. She told me at that visit that for the first time in approximately 8 years, she was waking up in the morning and feeling as though she had actually slept. Her husband reported that her leg kicking had dramatically reduced. Her evening crawling sensation was present but substantially less severe, a 4 out of 10 on her symptom severity scale rather than the 8 or 9 she had been rating it before the protocol. She had not been started on dopamine agonist medications, which I had deferred pending the response to the multi-mechanism approach, because avoiding augmentation risk in a 72-year-old with decades of potential treatment ahead of her was a clinical priority. Helen asked me the question I am asked most often after a visit like this one. She asked why none of the physicians she had seen in 8 years had ever asked her about this symptom, and why it had taken until she mentioned her husband's observation about her leg kicking to put the clinical picture together. The honest answer involves the structure of the medical appointment, the historical undervaluation of sleep-disrupting symptoms, and the underrepresentation of RLS education in general medical training relative to the condition's prevalence. But the answer that matters most for you is this: 12 years is the average diagnostic delay for restless leg syndrome. You do not have to be part of that average. I want to ask you one question before you close this video. When you lie down in bed at night, in the first hour before you fall asleep, do your legs feel still uncomfortable? Or do you feel something you would describe as uncomfortable, something that makes you want to move them? Be honest. And if it is the latter, tell me in the comments how long it has been going on. Because the range of answers in those comments tells me exactly how many people watching this have been carrying this for years, without the vocabulary to describe it, without the clinical framing to take it to a physician, and without the understanding that the sensation in their legs at night is connected to something far larger and far more important than a bad night's sleep. Now you have that understanding. Use it. Share this with someone in your life who mentions that their legs bother them at night, who kicks in their sleep according to their partner, who lies awake moving their legs and cannot explain why. The 12-year diagnostic delay is not inevitable. It ends with a conversation. This video is that conversation. Pass it on.